Okay, if we're ready, I'll go ahead and get us started live in 3, 2, 1. Hello, thank you for joining us. We'll give a few seconds for people to join the webinar and then we'll get started. Hi everyone, thanks for joining. We'll get started in just a moment. Okay. Good afternoon, everybody. Thanks for joining the webinar, Pennsylvania, the Transition to Treatment with Dr. Charles Barbera and Dr. Michael Boyd. Next slide, please. Before we start, I'd like to thank our funder, the Opioid Response Network. Next slide, please. The ORN was created to assist individuals and organizations by providing resources and technical assistance needed to locally address the opioid crisis. Next slide, please. Please go to opioidresponsenetwork.org for more information. And I'll turn the presentation over to Dr. Boyd.
All right, thank you very much. Good morning, everybody. Good afternoon. My name is Michael Boyd, and I'm an emergency physician in Heritage Valley Health System in Western Pennsylvania. And I'm joined today by Dr. Charles Barbera out of Reading, Pennsylvania. We are very honored to speak with you regarding Pennsylvania's experience with the opioid epidemic. And our focus of the conversation will be regarding transitioning patients to treatment for opioid use disorder. We are very proud to have worked through PACEP with the Department of Health with all of our various opioid initiatives, and we'd like to share some of those with you. I'd like to thank everybody at PACEP for all the work they've done. I can't name everybody individually because undoubtedly I would forget a few, but PACEP has done an amazing job in Pennsylvania regarding our initiatives with the opioid use disorder patients and the opioid epidemic. So to start off today for the agenda, we're going to give a brief overview of the opioid epidemic, discuss some prescription limitations and prescription drug monitoring program laws and regulations in PA, and then we'll move into the meat of the issue, which is our warm handoff programs, discuss some case examples, and then dive into some future developments. Next slide. So to start off, Pennsylvania was extremely hard hit by the opioid epidemic and continues to be, along with all of the states and kind of that Appalachian belt, Ohio, West Virginia, Kentucky. Dr. Kraus and Harry Monroe spoke in the first webinar regarding the overview of the opioid epidemic, and they did so in a wonderful way. And in response to the opioid epidemic in Pennsylvania, there was kind of a multi-pronged approach. Like most of the country, PA first focused on sort of the lower hanging fruit, the things that were easier to regulate, which would be prescription limitations. And so in 2014, providers were mandated to query the prescription drug monitoring program prior to each prescription for a controlled substance. In 2016, there was a law passed regarding limiting opioids to minors to less than 72 hours. And then in 2016, there was also a Safe Emergency Prescribing Act. And this was something that the Pennsylvania College of Emergency Physicians worked with the Department of Health and with our state lawmakers. Initially, there was actually not a lot of agreement on this bill. It was a bit controversial. And the reasoning was this bill singled out emergency physicians and said that we cannot prescribe greater than a 7-day supply. And PACEP wasn't against this because it was really a practice changer. None of us really prescribe more than 7 days. We see acute injury. So it wasn't that we were upset that we couldn't give people a month worth of opioids. It was upsetting because it was sort of framing the argument in a way that was singling out emergency physicians and creating a false narrative that we were the ones to blame for the opioid epidemic. And so although the bill and the law was not necessarily like the greatest win for us, it actually ended up translating into some longer term gains because it really got us in the same room as our state legislators in discussing the opioid epidemic. We got to really get a lot of face time and explain to them all the things that we experience on the front lines of that. And we were able to show that, we're not part of the problem, but we definitely want to be part of the solution. And so that really segued into a lot of the further discussions we'll have today regarding our transitions to treatments. I'd like to just highlight that because of all the advocacy work done here in Pennsylvania and across the nation, and that sometimes even if a law maybe isn't the best for you right off the bat, it does create some avenues and opportunities to create relationships with your state legislators so that you can be part of the solution going forward. And because of the conversations we had regarding that bill, that segued into a lot of the other developments that we had that were positive for us. So for instance, in 2018, there was an electronic prescribing law that mandated that you had to electronically prescribe every controlled substance. And for a lot of practical reasons, just isn't really possible from the ER. And so we did get an exception for emergency medicine to be excluded from that. And then in 2019, there was a mandate to have pain treatment agreements prior to prescribing opioids. And again, because of the relationships that we had formed, we were able to get an exclusion for that and make sure that those pain treatment agreements were only through primary physicians and for chronic pain, not for acute, broken bones and fractures, just because logistically that would really be quite difficult for us to do in the ER. Next slide. In terms of some of the victories we've had, in terms of the prescription limitations, the Pennsylvania Medical Society and PACEP, we developed some guidelines regarding prescription limits for us in the ER. And these really have come to fruition and have some direct results in reducing our prescriptions. So overall in Pennsylvania, across the board, between 2019 and 2018, there was a 10% reduction in prescriptions for opioids. And then since 2014, there was actually a 43% reduction in prescription opioids. So that did show that the limitations and the PDMP helped to prevent doctor shopping and really did help to get those prescriptions down. Some other initiatives would be the standing order for naloxone from the Secretary of Health, Dr. Levine, meaning that the general public and first responders can administer naloxone without a physician order. The general public can go into a pharmacy and get naloxone without a prescription. And so that's also been very helpful. And then additionally, the PDMP query prior to each prescription, as I mentioned, has helped to reduce doctor shopping. And the next slide. So now getting into the meat of this, the main thing we want to talk about today is the warm handoffs. And this came to be as a way of increasing our ability to provide treatment for opioid use disorder. Whenever we were talking to our lawmakers regarding the limitations on prescriptions, we said, that's a great idea. We need to reduce the pills that are out there, the total quantities. They're getting into the wrong hands and being misused. However, if we do not couple that with treatment, then patients are going to turn from prescription opioids to illicit opioids, and we're going to see a rise in our overdose deaths. And we were telling them this in 2014, 15, 16, and it actually unfortunately came to fruition. Our overdose deaths really spiked in 2016 and 2017. And I think partly to do with the fact that there was, a decrease in prescriptions, but also because of fentanyl into the drug supply and so forth. And so it was an unintended consequence in part to some of these bills. However, that also gave the opportunity to increase our ability to get patients into treatment. And that is called a warm handoff. So it sort of has a funny sounding name if you've never heard of it. But what a warm handoff is a transition for opioid use disorder patients directly from emergency medical care to substance use disorder treatment. So it's not just a referral. It's not just giving the patients a list of phone numbers on a piece of paper and saying, hey, you overdosed on heroin, go home and call these rehabs and maybe you'll get into somebody someday. It's exactly flipping that on its head. And it's giving them an actual contact while they're in the emergency department with a substance use disorder provider or a peer recovery specialist with a real-time in-person or over the telephone now conversation so that substance use disorder treatment can be arranged directly while they're in the ED. And a lot of times patients go directly from the ED directly to rehab or to an MAT program. So it's sort of like, if a patient comes in with a heart attack and we call cardiology, we don't say, oh, hey, here's a phone number, go call the cardiologist, right? The cardiologist comes to the ED, sees the patient, and treats them. Well, it's the same thing for an opioid overdose. If somebody overdoses or has OUD, they are in the ED, we get them directly in contact with that substance use provider in real time. This was a joint effort between the PA Department of Drug and Alcohol and the Pennsylvania Department of Health and the Pennsylvania College of Emergency Physicians. Next slide. Next slide, please. So this is a warm handoff care map that was created through PACEP and DOH. I know it's a little small here, but in general, it's a blueprint of a flow process. So if a patient presents to the emergency department with opioid overdose, or they're found to have opioid use disorder, they're there maybe for an abscess from using heroin, and you want to get them treated for their opioid use disorder. If they're going to be discharged home, you contact the person that's doing your warm handoffs. They speak to the patient while they're in the ER, meet them there in their time of need, form a therapeutic alliance, and then arrange for the appropriate treatment. If they're going to be admitted to the hospital, they can have this warm handoff done as an inpatient. And same if they're admitted to psychiatry, they can have this warm handoff done in a psychiatric unit. Next slide. And so what are these warm handoffs? What does it kind of entail? So the logistics of this is that Pennsylvania created 45 centers of excellence to focus on warm handoffs. And these centers of excellence were designed to engage the community, to identify people with opioid use disorder, and to take care of the whole person, including their OUD, their physical and their mental health. The centers of excellence are very diverse. Some of them are primary care practices, others are hospitals or federally qualified health centers. The warm handoff process in the state is such that although the blueprint overall is the same, how it's actually done logistically on the ground in each hospital is going to be dependent on what is available in that region. What works in Philadelphia will not work in rural Pennsylvania and will not work in Pittsburgh. And so those caveats and the individualized approach has been very important. So each hospital has been given the free range to sort of execute the warm handoff as what fits their own individual area while following an overall blueprint. There's also a Get Help Now hotline, which is a 24/7 hotline that patients can call, and they can determine and find out who the substance use providers are in their area. And there was a warm handoff task force created, which members of PACEP serve on, and they give recommendations to the Department of Health and the state legislature regarding how we can better perform our warm handoff programs. And then the next thing I'll touch on is, of course, you need to throw some money behind things if you really want to get interest. And this is a healthcare quality incentive program, which does just that. Next slide. So the healthcare quality incentive program is something that was set up through the PA Department of Health and Human Services, and they added a measure to their hospital quality incentive program pertaining specifically to opioids. And so they created 4 warm handoff pathways, and if hospitals implement and execute these warm handoff pathways, then they will be entitled to get additional funding. So the 4 pathways are an ED initiation of buprenorphine with a warm handoff, a direct warm handoff to the community, a specialized program for pregnant women, and also a direct inpatient pathway for methadone for observation or for buprenorphine induction. And so if your hospital implements and executes all 4 pathways, the hospital will get about $193,000 per year. So this was a way of sort of throwing in some financial incentive to the hospitals to get these warm handoffs done. To be honest, I'm happy to say that most hospitals, and specifically, I think the emergency physicians really took the lead on doing this prior to the quality incentive program because we knew it was the right thing to do. But the warm handoff program and the quality incentive really did help in throwing in some financial incentives behind that. So you can see that 77 hospitals in the state participated in all of these pathways in 2018. 44 participated in some, and 32 elected not to participate at all. In year 1, which was 2018, that you would get a process incentive, meaning if you just implemented these pathways and attest to making the pathways, you got the financial reimbursement. In 2019, you only got the reimbursement if you actually had a specified number of patients enter opioid use treatment. So what they did is look at your number of opioid use disorder visits to the ED, and then 7 days later, they ran insurance claims to see which of those patients actually had an insurance claim showing that they did get follow-up. And then if you had a certain number of patients enter into follow-up within 7 days of your admission to the emergency department, then you would qualify for that funding. So next slide. So basically, I know this was sort of a lot, and Pennsylvania did a lot together from a kind of a statewide mechanism. So if you're in a state right now where this isn't happening and you want to start a warm handoff process, it would be rather daunting to go and say, oh, let's go to the Department of Health right now and see if we can implement this. I'm sure if you went there, they would say, hey, have you heard of COVID? Our Department of Health is a little bit preoccupied right now. We can't be implementing a giant warm handoff statewide process and create 45 centers of excellence. However, I think you can do this just in your own department and in your own hospital. It just takes a little bit of innovation and championing on your behalf. So if I was going to start a warm handoff program from the ground up, and we didn't have any of this funding or didn't have any of the extras that go along with it that Pennsylvania has provided, kind of what would I do? The first thing would be find a champion. Find somebody who's going to be the cheerleader and get the ball rolling. By virtue of being on this webinar, I hereby decree you to be the champion, because if you have enough interest to listen to me babble on here, you probably have enough interest to get something started like this. So I would say that congratulations, you're now a warm handoff champion. And then you go there and you find out the resources that already exist in your community. I'm sure that everyone on this webinar has a rehab center or a community center or a church group or something in the area where people go for drug rehab. There are plenty of places that exist. It's just that it's a very complex matrix and it involves coordinating the care. That's really the harder issue. And so I would go to these rehab centers or to the detox centers in your area, ask to speak to the directors or get a little powwow together between all the directors of those centers that are around you and say, this is what we want to do. We want to create a direct transition of care from the ED to you. I bet you will find 1 or 2 dedicated case managers or peer recovery specialists or someone who already works there that would say, yeah, I wouldn't mind being the point person for this. I can take on this project. You can call me and I can talk to these patients in real time. And then once you get the ball rolling, other groups will kind of see what you're doing and they'll jump in too. They're fighting for patients just as much as anybody else is, especially with COVID. Some places have actually had a reduction in patients. So they might have a benefit as well as keeping their beds full. And if you can create a direct partnership and find those people in your area that are willing to take on your patients and perform the warm handoffs, I think you'll be successful. The third thing is, I would say, keeping it simple. The last thing an ER doc is going to do is sit around and call 15 different rehab centers and say, will you take my patient? Do you take this insurance? It's just not realistic. And the patients don't have the time for it or the patience for it. And so having one phone number to call or a call system, you call this rehab center at this time for these types of patients, you call that rehab center for these types of patients, you'll be able to create a more streamlined system. For instance, at our hospital, we literally have one phone number we call. Everybody knows the phone number. Everybody knows the guy who's going to answer the phone. And then from there, he kind of is able to talk to the patients, see what would best meet their needs, whether it's inpatient, outpatient, rehab, detox, and then let him be the person to actually determine where that patient goes along with the patient, of course. Fourth, it would track the data. That way you know how you're doing, figure out a way to figure out, how many patients are going into rehab and how many are not. And then 5 is set realistic expectations. This can be a very challenging patient population, as we all know. I think it would be unrealistic to expect the patient the next time you see with opioid overdose or heroin overdose, wake up and say, yes, sir, get me into treatment. I'd love to go right now. Right? The most people are going to say, no, thank you. It requires some motivational interviewing. I think the majority of our patients, I'd say over 50% actually decline the warm handoff process altogether. We like to get better at that, but that's just the nature of it. And then other ones will, change their minds. Some want to go, some decide, maybe not at this time. And so your success rate might only be 10, 15, 20% those first few months. And that's okay. It's a very difficult thing to get somebody to drop everything and go and start doing rehab or going and doing substance use treatment. So don't expect to have 100% success the very first few months. Next slide. So you can see here with our overdose deaths, what I mentioned earlier was in 2016 and 2017, we really had a spike of our deaths. Now we had a bit of a decline there from all drug deaths in 2018. 2019, it sort of plateaued with our 2018 numbers. So, I think we're making some progress. Unfortunately, 2020, we've heard anecdotally there have been more overdose deaths. We don't have the numbers, but it seems like that's the case. It has a lot to do with the shutdowns and COVID, of course. So it's constantly a moving target, but it's an epidemic that we have along with our COVID epidemic, and we're going to be fighting both of those simultaneously. Next slide. In the county that I work in, Beaver County, we've had really great success. This is just our overdose deaths. I mean, it's still quite a lot, don't get me wrong, but between 2016, we had 102 deaths. In 2018, we got that number down to 41. I think in large part that was due to a lot of the initiatives that we've enacted at our hospital and in our local area. And this is in a county of only 60,000 people. So 102 deaths and 41 deaths, that's quite a lot of people. So we've made improvements, but of course this is never going to end. We'll always be trying to fight the good fight. So with that, I'm going to turn over to Dr. Barbera.
Hey, thank you very much, Mike. My name's Chuck Barbera, and I am the former chair of emergency medicine at Reading Hospital, Tower Health, and now I oversee the service line of emergency urgent care and telehealth for the health system. Reading Hospital is a pretty big hospital, and the reason why I give you a background is to kind of put in some perspective of what our challenges were and what we did to meet those challenges. So we're an independent academic medical center. We have a catchment area of about 400,000. We see about 135,000 patients annually, and we realized that we weren't doing too well with our opioid overdose patients. And there were several instances where people would come into the emergency department, and very similar to many of us ED physicians, that we would reverse the person, say, with Narcan, and the person would pull out their IV and want to leave, and we would pretty much say, okay, fine, sure. And we would allow that to happen. And so we had some instances where we realized that this wasn't the right thing to do. Many where those patients that we would allow to leave came back, and during the second or third or fourth visit, there wasn't anything we could do for them. And then we kind of, as a hospital, realized we're not really fulfilling our mission here, are we? Initially, we would say, well, we're very busy. We had been, and maybe still are, the biggest ER in the Commonwealth of Pennsylvania, huge number of visits, and we constantly have a full waiting room. So when someone would want to leave, we'd be like, okay, well, we need that bed for someone else. We changed our approach to that after a patient that left after a reversal really hit home with many of us, and the patient left, went on to take care of their children, and then came back later that night, actually, with their 2 young children in an ambulance after a subsequent overdose that we were unable to reverse, and we were unable to revive the patient. And many of our staff realized, as we attempted to find care and coverage for their 2 children that were transported with the patient in the ambulance, that we really didn't do a good job here. and we got a team together to look at our processes, and we started a warm handoff program, and we worked with all the people that Dr. Boyd had mentioned to say, well, how are we going to figure this out? And so we started by talking about, like, how does the person come in? And usually in the emergency department, we say, well, how does the person come in? Either car or ambulance. And do we go through our ABCs, and do we do appropriate laboratory testing, and do we admit or refer the patient? And that's the way we normally would do things. And again, I think that I'll just give a brief introduction to what we did before we instituted the warm handoff. We would offer recovery, maybe, maybe not. If we couldn't get the patient to recovery, we did exactly what Dr. Boyd said. We gave them a phone number and said, good luck. And our actual single county authority, which is basically the Commonwealth of Pennsylvania's way of saying the person that has been designated the responsibility for the county for rehabilitation, drug rehabilitation services, the single county authority would give an open appointment to any ED patient at 0800 the next morning. Many times there was a long line, and it was first come, first serve. So many of our patients would get there, there'd be people ahead of them, and they would not stay. So then what we decided to do is we met with our certified recovery specialists and our single county authority, and we thought, well, what if we do this? What if we get someone else in the ED to help with this process? So what we do is we discovered that there are people out there, and I'm sure everyone on this webinar knows this, that is a CRS, Certified Recovery Specialist. And in Berks County, at least, these people are in recovery themselves that have gone through a certified course to become a recovery specialist. And there's really peer-to-peer interactions. And they can navigate the complex system, at least in the Commonwealth, but I'm sure everywhere in the country, for someone to get into recovery. And we brought these people on board, and we initially brought them on as an on-call basis, saying really the ED physician and the ED nursing staff need help in helping these patients. So we developed a new process where we have this certified recovery specialist. And when a person now comes into the emergency department, the emergency physician does what we did in 2015. We stabilize the patient. Once the patient is stabilized, we have Epic, which is our EMR here. We order a warm handoff in Epic. At that point, the recovery specialist meets with that patient in the emergency department to develop a treatment plan. Much like, as Dr. Boyd said, we would order a cardiology consult in the emergency department, and the cardiologist would come and meet with that patient to develop a treatment plan. One of the things, and I throw these things in to tell you where we kind of learned and misstepped, was when we initially started this, we had this person on call, much like we have our cardiologist on call, to continue that analogy. And so we would do a monthly average, and when we got the person on call, we would see an average, and we see an average of 3 overdoses a day. So about 90 to 100 overdoses a day we would see in the emergency department, or 90 to 100 overdoses a month we would see in the emergency department. And when we had the person on call, we realized that the patients were very seldom would they want to wait around for someone to come in to help them navigate through the process or do an on-call system. and wait for those persons. They would rather leave. So what we actually did, and it took some negotiating with the community, with our hospital and whatnot. We brought the recovery specialists in on our staff, and we treated them like any other emergency department employee, and we did an opt-out. So basically, the recovery specialist is called into an overdose unless the patient declines. And so instead of saying what we would normally say is, do you want to see a recovery specialist? Whereas 13 times out of 100, they would say yes, and the rest they'd say no. We would say, we are going to have a recovery specialist come in to see you, and give the patient the right to refuse. Most times they did not refuse. And we could see then that the amount of people that accepted the specialist once we embedded them in the emergency department was much higher, up to 75 a month, just accepting the interaction. I will go and say, well, then how did this turn out into people going into treatment? And what we saw was, before we instituted this 24/7 in-house, we would have about 9 people a month going to treatment from the ED. Once we had this person in-house, we saw about 44 people on average a month going right into treatment directly from the emergency department. And we considered this a success. I think it was like a 68% success rate right into treatment from the emergency department. So as you look at the year, this is 2018 data, you can see that we had nearly 1,000 encounters. Half of them were heroin and opioids, and many of them, 68%, accepted treatment right from the ED. What's important to note is that we realized that we were missing a huge population when we narrowed our focus to heroin and opioids. So we expanded it to all substance abuse. And the second, actually the largest, in Reading at least, the largest substance we see abused is alcohol. And once we utilized this certified recovery specialist for alcohol and opioids, we realized we had a lot of opportunity, and we saw a very, very large acceptance of treatment right from the ED. Some of the reasons for this was that we were able to have almost a mini intervention in the emergency department. So we realized the best chance we could of getting someone into treatment was to be in the ED when their loved ones were around them and when they almost lost their lives. And every day that we allowed that patient to go home and follow up as an outpatient, we lost some of that momentum and some of that history and support that we got by turning our ED into an area where a recovery specialist, a patient, and those people that are most important to that patient can sit around and talk about what the patient's goals are in a very frank and open yet non-threatening environment, because the ED was really the hospital and not necessarily a home or somewhere else where there could be competing priorities. So I think we kind of felt that was a successful program. We have gone on to expand that program to utilize telehealth services, to utilize medical assistant treatment, to start that in the emergency department, to get consults real time with addiction recovery specialists and physicians that are specialized in addiction medicine that can also begin MAT as all our ED docs can, and then follow up. So likewise, for the warm handoff encounters where we got people directly into treatment, we started phase 2 where we had a 5-day a week, wish it was 7, it is only 5, return time for those people who we begin on buprenorphine in the emergency department, and they are seen the next business day in our addiction medicine clinic by an addiction medicine specialist. When we tried to begin buprenorphine without that immediate referral, we realized we were losing a lot of people that were not following up with the program. So that's kind of, I wanted to switch gears a little bit and go to what Dr. Boyd had talked about, which was the Pennsylvania standing order for naloxone. So basically, as Dr. Boyd said, the standing order allows anyone, any pharmacist in the Commonwealth of Pennsylvania to dispense naloxone to someone without requiring a individual prescription. It is a prescription medication, and the prescription is covered by the physician general, Dr. Levine in our case in Pennsylvania, and she, in essence, writes that prescription for anyone that wants it. So we don't need an order in Epic. We were fortunate that our single county authority was willing to provide this drug free of charge to our patients, yet because our hospital is not a pharmacy, we were not able to distribute it. Our single county authority realized that they were not having success distributing it from their office because people weren't going to their office to get it. And they approached us and said, well, you know, the best place to get this drug is if someone goes to the ED and then decides they don't want to go to treatment, and we have about 1/3 of our people that don't want treatment. What else can we do? So we developed this process again in Epic, where we have the warm handoff counselor who assesses a patient, and that counselor will do their best to get that person into treatment. If they are not able to, they have the ability to put an order in for a naloxone kit. And then the patient, or many times their loved ones, will get the naloxone kit that we keep in the emergency department for this reason. So basically, the kit allows the patient to leave with nasal naloxone. We fill out an information sheet so that we can keep track of where the supply is, should there be a recall, and so that we can contact the patient for follow-up later if need be. So there is a tracking mechanism for this, but it actually works very, very well for us, that there's no charge to the patient. The kit is supplied by a grant from the Commonwealth of Pennsylvania, and yet we are able to distribute it, not prescribe it, but distribute it through our emergency department. We actually keep them in the Omnicell, which is our medication tracking system, so that when we run out, the Council on Chemical Abuse knows about it, and then they can replenish the supply. And again, this is the kit. This is what the naloxone looks like. Again, it is sealed. We keep the expiration date. The education, we actually show a YouTube video to the patient on our patient education system in each room, and it's stored in a medication dispensing cabinet. And the Council on Chemical Abuse is automatically emailed when the supply is low. We made a cute little kind of, it looks like when we were kids, you had these lunch boxes, and we have these little lunch boxes that we keep them in with the instructions and everything. And so a patient will go back, will be given this lunchbox with all the information inside it, as well as other resources. You can see that this kit that we did for this picture expires 1/2001, where we would have to take that back. And there's tape on it, so if it's been tampered with, we would know not to use this. And what's in the kit is the naloxone, a face shield, gloves, antiseptic wipes, how to use it, the utilization report, and then obviously where to go for more information. Finally, the only thing that we had was, this was difficult. The most difficult thing for us was getting the staff to adapt to this. This was not the way we had traditionally done business. And for an ED, and a pretty busy ED, it was tough to get out of the mindset that everything we did had to be fast, and everything we had to do had to focus on room turnaround and getting people in and out. And that there were times when the quality of the care we were provided was more important than the timeliness. And again, depending on where you sit, Medicare looks at us and says, if your length of stay is long, we aren't going to give you as many stars. And we know that we like to have stars, but we also like to do good for our patients. And to weigh that, many times administration looks at stars and maybe not necessarily at the good. There were a lot of privacy hurdles. People would say, well, wait a minute, if someone comes in and you get a recovery specialist, aren't you violating HIPAA? And we're like, no, we're not violating HIPAA because they work for us. They're part of what we do. We don't violate HIPAA when we get a social worker to come in. We don't violate HIPAA when we get a cardiologist to come in. We are not violating HIPAA here. Funding was a huge problem. We were fortunate when we sat down here, we had a 3-streamed funding process where a third of our funding was paid for by the Commonwealth of Pennsylvania. A third was paid for by Tower Health. And actually a third was paid for by Community Care Behavioral Health, which is the insurance carve out for mental health in southeastern Pennsylvania. They realized that they were paying a lot of money too. So most of this was funded not through the hospital operations, but through other funds. And then finally, access to the EMR, ours is Epic. It was challenging, although we were able to do it, to build these pathways into Epic. And so they were some challenges. And what we're doing, again, we're trying to model now a warm handoff hotline. Much like Dr. Boyd had talked about what they're doing and using either telehealth for this or some other model where we could have one warm handoff recovery specialist for the entire health system. We're kind of struggling to see if that's reimbursable or not. And then to look at, wait, Mike, is this your slide or mine?
It's my slide. It's my slide, but you've been doing a fantastic
job. Mike, I'm going to go to Mike. You know what? I looked at this, and now when I got to the bed registry, I thought this is Mike's thing, not me. So with that, I am going to turn this back over to Mike Boyd. I am sorry, Dr. Boyd, for taking your slide.
It's okay. You fooled me. I thought it was your slide as well. You did such a great job with it. I mean, all I really have to add to this, we're talking about future innovations. I think Dr. Barbera described his program in great detail, and it's really great to see a tangible way of how you can actually implement this. And in terms of this warm handoff hotline, that's basically like a poison control hotline where it's available 24/7, where either the patient or a hospital could call. If you're a rural hospital that only has a few, very few visits, and you're not going to be able to have someone there 24/7, it would be nice to have a hotline that you can call and have that person on the other end speak to the patient and help them to coordinate where their care will be. A telehealth reimbursement is really important. We've been fighting for this for a long time, and now obviously with COVID, it's even more important. Many of our warm handoffs have actually gone to over the phone rather than in person because we're limiting the number of people that can come into the ER. So getting reimbursement for that and helping the patients get reimbursement whenever they go to an outpatient provider. There's no reason why MAT can't be initiated on an outpatient telehealth visit, and that will help increase their access to care. And then a bed registry, which essentially would be a platform online for a bed search. So instead of peer recovery specialists calling rehab or detox centers asking if they have beds, you can actually look online in real time and see these places have beds, and that cuts down a lot of the time and a lot of the logistics to help expedite these warm handoffs. So those are some future innovations we're working on and hoping for. And so I think I'd like to thank Dr. Barbera for everything you spoke about very eloquently, and the success you've had with your program. It's probably the most successful program in the state, and it's been incredibly wonderful everything you're doing for your community. So with that, we can conclude. And if anyone has any questions, please type them in, and we'd be happy to stay on and take some questions.
Okay, I see a question in the Q&A box.
Dr. Barbera, do you want to take that one? Because I think you use a little bit more recovery specialists than I do.
I will tell you that's a great question, and so we have many, to be honest, are our former patients of ours, and so one of the things that we noticed, the Council on Chemical Abuse, which is our single county authority here, they have had a program where they really kind of a back to work program where they have trained peer recovery specialists, and they trained a lot of them. So initially we had very little problem getting workforce because they would have people that had been in recovery that had needed employment, and we could give them employment with us. And so that worked out very well. As the program went on, especially as it became a 24/7 program, we struggled a little more because nights aren't obvious. People didn't want to work nights. Evenings were tough. And so we now staff with 2 full-time people and a bunch of per diems that help us. But really, these people come from the Council on Chemical Abuse or our single county authority. We do not train them.
Okay, I don't see any further questions at this time. Oh, sorry, one more just came through.
So the question concerning alcohol use disorder, I think that's actually a really good point. And most of this has been focused on opioids, and a lot of the initiatives were geared around opioids, but I would say half of our warm handoffs are for non-opioids or for polysubstance and for alcohol. And that's really been a really pleasant unintended consequence. Alcohol disorder has been grandfathered in as it's, there's an alcoholic at the time we discharge them. And that's been around for so long that you don't really think about it. But in essence, we offer every person with alcohol issues the same exact warm handoff. And I would say half or maybe even over half have been for alcohol use. It can get a little tricky because if they're going to go through withdrawal, that may limit where they can go. And so that warm handoff can come as an inpatient if they're admitted for a medical detox. But there's many times too where we can give them a prescription for Librium or Valium and have them follow up through a warm handoff as an outpatient. So that's a great point, that there's been a really nice positive unintended benefit of implementing the warm handoff program. And there's a question about referrals from a local alcohol use disorder detox center. Do you mean referring? If you mean referring them to the ED, then yes. A lot of times, if a patient will go to detox and they become too much, they require too high a level of care, they will send them to the hospital to be admitted to the ICU. We can medically manage them better than some of our detox centers. We can also refer patients to our local alcohol use disorder detox centers as well. We have I think Dr. Barbera is probably in the same boat. We have a variety of places we send patients to. It's not just one rehab center or one detox. There are a variety of rehab centers. And there's also just MAT providers, whether the patient needs inpatient or outpatient or rehab or detox. It's variable. So we utilize a lot of the resources in the area.
Yeah, and with alcohol, it is a little tougher for us because sometimes the payers will control where the person goes. And I guess that's true with opioids too, but alcohol more, whereas our opioid use disorder is mostly covered by the mental health carve out. Many times alcohol is covered sometimes by their health insurance, which may dictate something different than a normal referral pattern.
Okay, thank you all so much for your participation today. I'm going to be sending out an email with a recording of the webinar, as well as a link to the previous webinars in this series. And I'll also be sending information for our next upcoming webinar in the series. That's Washington State, Collaborating to Fight the Epidemic. So again, thank you so much, Dr. Boyd and Dr. Barbera, for your time today. And thank you all for your participation.